Hi, Casey. Happy Friday.
I am so excited about Friday.
You don't sound like you mean it. That's okay. Well, I'm excited. The thing I'm most excited about today is talking to Dr. Coffler because I wanted to get him on our podcast because, first of all, I miss him. I love him. He is so great. I spent a lot of time working with him, and he was my intro, like my entry into even working in this field. So I owe him a lot, but I've learned so much from him over the years. And I know I talk about him all the time, and Ivana does too. So I'm excited for you to meet him. He's so wonderful and kind and has so much passion about fertility and helping people build their families and making sure that people understand what they need to do if building a family is something that's important to them. They need to know all the tools at their disposal.
I cannot wait.
And I believe you. Casey, today is a really weird day. Hi, I'm so excited, Dr. Coffler, that you said you wanted to be on our podcast because I've been thinking for years about you. I follow you on social. I know social's not your favorite fun thing to do, but you have a lot of fun updates going on at your office. How long has it been since I've seen you? Has it been?
Oh my God, I can't even remember how many years, but we still, I personally still miss working with you. And I think when you left, Ivana started working with me, right? You
Mm-hmm.
you recommended,
Yep.
yeah,
Like,
and
I have somebody better for
both,
you.
both of you were wonderful. Both of you were wonderful. Like I really, again, what can I say? I mean, miss working with you, but life is life, I guess. So
Yeah,
I'm
well,
I'm
I'm
sure
sure
you are
you
in a
will.
in a better place where you want to be, and that's great. I'm happy for you.
Yeah, well, we're growing our agency and supporting surrogates, and that's always what I've been passionate about, and so it's really been fun. But one of the things that always stands out to me and what I wanted to talk to you about today is on your lunch and learns with the OBs and their offices. You would always focus on female fertility and how rapidly it declines and how few women realize how our fertility works until it's too late, until we have a problem. And so I always, after I would go to one of your lunch and learns, or I would sit with you in those, I would be telling all of my friends, like, you have to freeze your eggs. You have, like, if you ever want to have kids, or if you think you might want to have kids, we got to talk about this. And they're like, what? In their late 20s, I'm old now, but back
You
then I
don't
had
look old. You are not.
my eggs are toast, but I remember it was really eye-opening for me listening to you talk about it. I had no idea, and I think most women have no idea. So I'm excited for you to be able to share that with our podcast listeners today.
Yes, I'm looking forward to that. And yes, you are absolutely correct. This is one of the things that I am, first of all, very passionate about. And as I don't know if you remember, but I have four daughters. So I'm very, very aware in my personal life, and how things can be different for women and versus men. And when I grew up, I have a brother. I don't have a sister, so for me, it wasn't ever an issue. But now, having first of all working in this profession and having four girls, it hits you. Definitely makes you think about it and be very aware of that. And I'm sure we'll talk about it
Yeah, it's one of those
during
things
this.
that another thing that's just not fair for men and women. That is just something that we really have to think about and be mindful of.
Correct.
And
Yeah.
how lucky those four girls are. I have four girls myself, so I know what that process looks like, and it's a beautiful journey. That's for sure.
Yeah, enjoy every moment because before you know, it's gonna be it's gonna be over.
Yeah.
They fly away.
Oh, she has four daughters too. That's crazy. You guys have all the women in the world. And for those who don't know you, Dr. Koffler, do you want to introduce yourself and tell our listeners a little bit about you and your practice and what
Of
you've
course.
been up to?
So I practice at HRC Fertility, so I'm one of the many physicians that they have now. So this practice has grown significantly since we actually, since I started a few years ago. Uh, but I joined HRC in 2008, and then I've been there. I've been with them since then. Our practice started in Oceanside. So I actually initially worked in Orange County, but then I live in Carlsbad in San Diego area. So we decided, HRC decided to open a local office, and the first one was in Oceanside, and the office slowly grew and advanced, and we gained more and more patient population in the San Diego area. And now, eventually, lately, we moved to a new location, a bigger office in Carlsbad. And in addition to that, we opened a full service uh, practice, or a full service center in San Diego. So we have now in San Diego region, we have two offices: the satellite office in Carlsbad, which we started with, and then a new center for the last year and a half. We have a new center in San Diego area, and it provides the full services of IVF, egg donation, surrogacy, fertility preservation, anything you can think of. So I personally have been in this uh, for in REI for more than 20 years. I've been practicing here in the U.S. Prior to that, I was practicing outside of the U.S. But anyway, now I'm here, and I've been enjoying doing that every single moment. And like you'll see soon, I'm really passionate, like I said, about uh, building families and definitely fertility preservation for women that either don't have the opportunity to start a family right now, or facing other situations where they need it.
Yeah. Yeah.
Well, I am really excited to talk with you about that because it is something that you've really opened my eyes to over the years. And I think more women need to be aware and hear about how important it is because we don't really think, I think people are starting families later and later. It's expensive to start a family these days, and a lot of people are waiting until they get their careers more established and they're feeling more financially stable, which for most of us doesn't happen in our early 20s. It happens in our late 30s when we're like, okay, I'm ready. So I guess I would love for you to share a little bit about what is fertility preservation and kind of the importance of the differences for it between men and women, like thinking about fertility preservation.
Okay. Yeah, I'll be happy to expand about that. So let's start with women, and then we can talk about. But generally, it's true. Fertility preservation is for both men and women. But basically, it's a process of saving or protecting eggs, sperm, or generally reproductive tissue, so that a person can have basically biological children in the future. And this can be done for a variety of reasons. For example, medical conditions, which was initially the main purpose of fertility preservation, like cancer treatment that would essentially chemotherapy or radiation that can damage reproductive organs and can make it difficult to conceive naturally. So fertility preservation can allow these individuals to have children after they complete treatment. Um, Other reason that you mentioned is delayed childbearing, which becomes basically the major reason nowadays, at least in women. So people who choose to delay childbearing for professional or personal reasons, they may want to preserve their fertility as a backup option. And then other conditions or other reasons can be gender identity. So transgender individuals who want to have biological children may choose to preserve their fertility before undergoing either hormone therapy or gender affirming surgery. There are other examples, but those are definitely some of the situations where fertility preservation is beneficial. And essentially, again, like I said, it's basically preserving the ability to or in a way, it's not totally preserved. It's not a guaranteed process, but it's preserving in general the ability to get pregnant after a certain timeline for a certain timeline in the future. There are different methods for fertility preservation, and it depends on the individual needs and circumstances. So, for example, we can talk about egg freezing, and we can expand later about each one of them. In men, we talk about sperm freezing. We can talk about embryo freezing or embryo banking, or even ovarian tissue freezing, which we personally don't offer it, but some academic centers and some centers across the US, they can offer this technology, which is suitable for a more specific population. Generally, when we talk about fertility preservation, ovarian tissue freezing is not the most popular or the most common method that we use.
I've never even heard of it.
Yeah, I was going to say, please, what is that?
What's the purpose?
So essentially, it's undergoing. You need to undergo surgery and remove pieces of the ovary, essentially freeze them, and then use them later when the time is right, when they're needed.
Huh.
What
Like
would
I
they
said,
be needed for? I guess I.
so, for instance, if you have young women, young girls that do not have a period, you can't freeze their eggs, then you can't retrieve eggs to freeze them.
Oh,
That would be
wow.
a segment of the population that this technique can be helpful for them. So young girls
So
that
if you have a young girl with cancer diagnosis
correct.
or something.
Correct.
Then you
Okay.
could, wow. I didn't even know that was
Wow.
an option. How
Me
beautiful.
neither.
Gosh.
It's not the most, I would say, success rates with that technique are not as great as egg freezing or embryo banking, but
It's an
at least it's an
alternative if
option.
there's no other options, which is
Correct.
beautiful to know that that's even
Available.
possibility. Yeah, that's
Yeah.
great. At what stage would a woman start considering freezing her eggs, and how does that impact the success of that outcome, her starting sooner than later? Can you elaborate on that?
Of course. As women age, as you know, the fertility decreases, and really the risk of an chromosomally abnormal embryo increases, right? So it's not only that the fertility goes down. Basically, when you get pregnant, as you know, after the age of 35, I'm sure even now there is a recommendation to consider amniocentesis, because there is a higher risk of having a fetus that is maybe affected by a chromosomal anomaly like Down syndrome, right? So we know that with advancing age, you are less likely to get pregnant, and more likely, if you get pregnant, to have a chromosomally affected fetus. So actually, the decline in pregnancy rates begin as early as the age of 32.
Wow.
And that's most people may not be aware of that, but then by the age of 45, essentially 99% of women are infertile. So during this period from 32 to 45, there is a gradual and then a more rapid decline in women fertility. So then, what would be the target population, right? The target population to counsel them about fertility preservation most likely are women between 30 and 37-year-old. So that would be I would say the segment of women that are going to be benefiting most of this technology. Also, I would definitely counsel women that are maybe even younger, but that they have diminished ovarian reserve. So nowadays you can test ovarian reserve by either doing an ultrasound and looking at and counting the number of follicles in the ovary, or doing a blood test that it's called AMH, anti-Mullerian hormone. And by getting this information, you can identify women that are at risk or already have, even if they are younger than 32, but they already have a diminished, a lower ovarian reserve. So those women would also be good candidates for fertility preservation, because, of course, the older they get, their ovarian reserve is going to be even lower. Yeah. And that may negatively affect their potential of pregnancy in the future.
Mm.
So, and then lastly, you can also consider patients that have a family history of premature menopause. So even if they're young, but you know that their mother and grandmother and so on had early menopause, then these girls are going to be also at risk for premature menopause. So they would be also candidates for fertility preservation, even though they're not, you know, in that 32 to or 30 to 37 age group.
Right.
So there are multiple considerations that that you can consider when you're talking about, you know, when you're offering someone to think about fertility preservation.
Mm.
And then other factors that you consider when you do that are, you know, what is the anticipated time between when when do you want to start actually how long do you want to delay your family building? Like if the longer you want to delay it, then the harder it's going to be for you to start a family. So you should then consider doing this procedure, because if you wait for the last moment, it may be already too late.
Yeah.
How many kids you want? If it's a different thing if you want, you have to plan differently. If you are 30 and you want, 6 children, or you want only 2 children. If you want 6 children, you're not going to be 30 for your fourth or fifth or sixth child. So then, you may consider that as well. You may consider that as an option, because typically patients are not going to deliver a baby and come back and get pregnant again. I mean, for some women it does happen, but most they don't. So if you want a larger family, then you may consider that as well as an option to, to give a good chance to yourself to have the family size that you want, when you get older. Another group are going to be women that you already know that they have, or they may have potential barriers for natural conception. Like, for example, you know that someone is young, maybe may have an excellent ovarian reserve, but has endometriosis. She was diagnosed with an endometriosis. You know that endometriosis is going to negatively affect their fertility, and it may get worse in the future. So such a woman may not need to wait till she's 37 to find out that she has a fertility problem. She already has one. She already has endometriosis, and it may only get worse. So someone like that may already think about, okay, let's save my eggs now, because even if I'm, let's say, 26, let's save my eggs now, because when I'm going to be 32, 34, or 35, and I'm going to be ready to start a family, maybe by then my ovaries are going to be so much negatively affected by this process that it may be then very hard or impossible to be pregnant. Women that have tubal disease, that have had pelvic infections, again, they may, even if they are young, they may already have tubal disease that is going to affect their ability again to get pregnant when they try later in the future, and they may need IVF anyway. So again, this is another group that they may consider freezing eggs when they are younger rather than they are older, because their egg number and quality is going to be better. We can keep talking about it, but again, women with polycystic ovaries, that's another huge group of patients, right?
Huge group.
There's many of them. So women with polycystic ovaries, again, they have irregular cycles. They may already have issues getting pregnant. The older they're going to get, it's just going to become more and more challenging, even with medications. Even if you can induce ovulation and get them to ovulate, these women may have situations where, may encounter a situation where pregnancy is going to be impossible because of decreased egg quantity and quality, mainly quality.
Do you think anybody is talking to these women in these populations about this, or is it just if they happen to be so lucky to go talk to an REI that they're going to get this information? Are there doctors talking to them about it, do you think?
I want to believe that they do, but realistically, I'm afraid that most, are not minded to that. I think because when you see the patients that come in and you talk to them, and most of them will tell you, or almost all of them, actually, I don't think that anyone ever told me that oh yeah, my doctor told me to freeze my eggs when I was, 30,
Yeah.
but I
Right.
didn't.
Yeah.
Actually, everyone tells you, and if you look, if you hear about the media and social media and the news, I don't remember who was the last one, but I think it was one of these, high profile Hollywood figures
Sure.
that can't get pregnant, and she's struggling, and she has a lot of, she has failed infertility treatments. Also mentioned, hey, I wish someone would have told me to freeze my eggs when I was,
Yeah.
in my early 30s. And unfortunately, I think there is a lack of awareness.
Education. Yeah. And I think that even women that we are considering to qualify for surrogacy, to realize that there are so few women that actually truly qualify based off of, carrying a successful pregnancy or having trouble on their own, being able to keep that pregnancy is just, it's just an awareness, I think, that we are now kind of scratching the surface and understanding and trying to educate others on. For somebody who is unfamiliar with the freezing process, can you share a little bit about what would that look like if somebody were to take those steps and do egg freezing?
So let me just quickly give you just an overview about egg freezing, okay? Because egg freezing is, when you say it, it's kind of okay. It's like, when did it start? It's good to know just a little bit of background about of it. So
Please.
really, egg freezing is existing for decades. Believe it or not, it doesn't start yesterday, but methods have changed. So uh, actually, the technology improved in the more recent years, and that resulted in this widespread clinical use of it. Because prior to that, success rates were quite low. The first human pregnancy that was basically reported from egg freezing was in 1986.
Mm.
So that was a baby that was born from a previously frozen egg.
Wow.
So with the newer technology that we use more recently, which is called vitrification, I don't know if you guys heard about it.
No.
There were two techniques. The first technique that was used to be, that used to be used to be used for freezing eggs, it was called slow freezing. And with the slow freezing, the problem was that um, the eggs, there was intracellular ice crystal formation inside the eggs. And when you were warming those eggs, they would be damaged. So essentially, they would die.
Mm.
And many of them would not be then useful. And then with this newer technology, which is called vitrification, which is basically flash freezing of the egg, you just drop it in liquid nitrogen. That basically prevents this formation of these ice crystals. So then there is an improved uh, post-warming oocyte survival. So then
Wow.
you get a better chance of using those eggs when you need to use them. Um, until 2013, egg freezing was considered an investigational or an experimental process. And then in 2013, the American Society of Reproductive Medicine, the practice committee declared or stated that oocyte freezing is not experimental anymore. So that allowed for its initial use or routine, not initial. I said it was years ago, but for a more routine use in obviously in women that are post-menarcheal. That means that they are reproductively capable. Okay, and the initial intention was to use it for women that are undergoing chemotherapy.
Mm.
So to preserve their fertility. Later, because this process has been became so popular and became so successful, it became more widespread. So
Mm.
now, actually, the main use for it is not for women that are undergoing chemotherapy. That's a small proportion of the patients. Actually, the majority of the patients are those that are doing it for what we call like more social reasons. For childbearing for delaying childbearing. Sorry.
Yeah. Yeah.
Now, the process itself, it's similar to IVF. It's a it's it involves self-administration of ovarian stimulation medications
Mm.
for about an average of 10 to 12 days. During this period, women are required, like in IVF, to be monitored in our office for ultrasounds and blood tests to assess their progress through the process. When we establish towards the end of these 10 to 12 days, that the eggs are ready to be retrieved, then patients will be instructed to self-administer a final shot that it's called a trigger shot, and then present to our surgery center about 36 hours later for a vaginal ultrasound-guided egg retrieval, which is done under anesthesia. And then the retrieved eggs are handed to our embryology team, which is then processing them and freezes them the same day in liquid nitrogen, and that they can be kept then frozen as long as the patient requires it. So they can be kept frozen for a year, 2, 5, 10, technically indefinite. As long as you keep them in liquid nitrogen, you can keep them essentially indefinitely. Now, I don't know if you want to jump into that right now, but we talked about the possibility of fertility preservation for actually embryo banking, not just egg freezing. So, if there are women that prefer to bank embryos, which I can, I will touch on that in a second. But once we retrieve the eggs, instead of freezing the eggs, we can fertilize those eggs either with, if the patient has a partner, then with a partner sperm, or she may choose to use donor sperm, and then we create embryos. When fertilization is confirmed of these eggs, then the embryo development is then monitored over between 5 to 7 days, and then the optimally developing embryos, those that look good, that have are good quality embryos, after 5 to 7 days, then we can, at that stage, we can sample them. We can do what is called genetic screening, the PGTA test, the pre-implantation genetic testing. We sample a few cells from each embryo, and then we freeze them. And the advantage of this process is that now it takes about a week to get results. In the future, it may take much shorter. But then we get genetic characterization of these embryos. So now you didn't just freeze eggs, you actually froze embryos, and in a few days now, again, you will know if those embryos are chromosomally normal or not. When you freeze eggs, you don't have this knowledge. And then at that point, you don't know, you just know you froze some eggs. You hope that those eggs that you froze are good, but you don't know that. When you freeze embryos, you have much more information. You basically can make then the decision, because if, God forbid, let's say you don't have normal embryos from this process, then you may choose to either you say, okay, you give up, or you can try it again until you get normal embryos and the amount of embryos that you would feel comfortable that you need, for your future family plans. So let's say you want 2 kids, then ideally you should freeze at least 2 embryos that are chromosomally normal. And that would give you a decent chance to have 2 kids in the future. If you want 6 kids, then again, you'll freeze more embryos that are chromosomally normal. But that gives you the information, that gives you the ability to make informed decision more than just freezing eggs
That's
by
such a good
themselves.
point. I didn't think about, because if you freeze your eggs, you could get all these eggs and you could freeze them, and then by the time you're ready to use them, they can be not good.
So realistically, they're going to be the chances. Keep in mind again. Let's and we can touch that. Basically, when you freeze eggs, again, you don't know if those eggs, even when you froze them, even from a young person, you don't know if those eggs are good quality eggs or not.
Right.
You just know that you're freezing eggs, and there is a chance that those eggs are going to become babies in the future. But it's not because you froze them for 1 year or 10 years or 15 years. It's not necessarily going to deteriorate the quality of the egg. The quality of the egg is going to be established, or is established, based on the age, on the age that you froze the egg. So if you froze an egg when you're 25 years old, you're going to more likely freeze a better quality egg than you are 35 years old.
Yeah.
Even let me give you an example. If let's say that the chance to have a child, if you froze 10 eggs, okay, there is about a 70% chance. I think I'm not mistaken. I think there is about a 70% chance that you're gonna get at least one kid, okay, out of these 10 eggs.
Out of 10?
Yes.
Wow.
Yes, exactly. Wow. But there is so only 70%. I mean, out of 10 eggs, right? So it's not 100.
Yeah.
But if you freeze 10 eggs when you are 40, guess what's going to be your chance to have one child? Only
Yeah.
about 30%.
Right. Wow.
For the same number of eggs. Okay. Why? Because when you freeze them when you are 40, the quality of these eggs is going to be significantly lower.
Sure.
So even for the same number, the younger you are, there is a higher chance. But how did we get to that? We got to that topic because we were talking about, okay, when you freeze eggs, what do you know? You know that you freeze a chance. You freeze a chance, and the chance is going to be the chance at your age of freezing those eggs. So, like I said, if
The
you
younger, the
freeze,
better.
yeah, exactly.
Yeah.
Exactly. I mean, there is no question about that.
Yeah.
So
those odds are in your favor for sure than the alternative, which makes sense. What would that typical cost for freezing eggs if somebody was looking into this? And is this something that insurance covers?
I can tell you the cost at HRC. I mean, I just looked into that this morning, but the cost at HRC to freeze eggs is $8,200. Now it's $8,250. Okay, and that's for one cycle. So if you choose to freeze eggs, that's going to be the cost. The cost of medications, can be up to $5,000 in addition to that. And then there is an annual fee for keeping those eggs frozen because they are kept in the lab. They don't just sit there and they have to be maintained. Those tanks that the eggs are stored in, and that's the fee for that is $850 for every year that you want to keep them. So
and that probably goes up every year or is reassessed every year?
Well, when prices, like I know that prices went up recently. I think that up to March 1st, it was only $7,900. So the cost went up a little bit. And yeah,
so
I mean,
it would be $8,250 for the process of the retrieval plus approximately $5,000 for the medications.
Yeah.
And then $850 a year. So it's not cheap.
No, it's not. And unfortunately, most patients are not going to have coverage for that. There are some employers, at least here in California, that purchase this, service, this coverage for their employees. But it really depends on the employer. It's not the insurance.
Common. Yeah, that's a bummer.
Here in San Diego, to be honest, I think here in San Diego, many employers, many of my patients do have coverage, some insurance coverage. But again, it's very individual. I guess it depends on the location that you are, the employer.
If you have that coverage, you should absolutely take advantage of it because what a huge benefit. And Casey and I were having this debate yesterday, and maybe you can help us answer this question because we were talking about how female fertility declines rapidly as we age. She was thinking, correct me if I'm wrong, Casey, I think you were thinking that you lose the amount of eggs with every cycle that you have, and that's why you run out of eggs. And I was thinking that it's not that the eggs disappear, but that the quality goes down. So I guess how many eggs does an average woman have, like from the get-go? And then is it that the eggs disappear, or what happens? Why does our fertility decline so rapidly as we age?
And I know that there's age, right? Because they say after a certain age, but I was kind of under the impression that it's a little bit of both, that there is the two-part, that there's the amount of eggs that you have and that dissipates, and then the quality also dissipates as you get older as well.
But then if the amount goes away, like where did they go? Why and how did they go?
Scientifically, it's called programmed cell death. It doesn't mean a lot. It's basically it's a scientific term. But what happens is that women are, when they are fetuses, basically they start the eggs in their ovaries multiply until a peak at about 20 weeks. So we're there in the uterus still. That's when they have the peak number of eggs. And from that time on, it just goes downhill. So what happens is that, so before even you use your eggs, the number of eggs in your ovaries starts declining. Why is this process like that? Nobody knows. But when you are 20 weeks embryo, when you're a 20 weeks egg, you have about 5-6 million eggs in your ovaries totally. And then when you are born, believe it or not, you're left with about 2 million.
Wow.
So
Wow.
that's right. So you lost most of your eggs when you're a fetus, when you're an embryo, when you're developing, you're not born yet, and you lost already most of your eggs. And then between birth and when you become reproductive capable, right, when you get your first period and you become reproductive capable, you lost another 1.5 million.
Oh.
So now you're left with about, let's say, 500,000 eggs. Okay, and then that's let's say that's the age of, usually it's the age of right on average about 12 in the US.
Right.
But let's say it's 10. Let's say it's just for the purpose of calculation, make it easy. Then when you hit menopause, and that's the average in the US is about 51, but let's say it's 50. Okay. Then you have no more eggs. All your eggs are gone. Technically, all your eggs in the ovaries are gone. So between the age of 10 and 50, which is, let's say, it's 12 and 51, but again, just to make it simple, so between these 40 years, from 50 to 10, 40 years, you lose about 500,000 eggs over time.
Yeah.
And those eggs are spontaneously dying, while during this time you typically ovulate one of them. Okay, so every month you're going to ovulate one of them, and you may lose on average, if you do the math, I don't know, like about 800 eggs a month, just more or less. But you only ovulate one.
Yeah.
So the eggs that you lose are much farther. The quantity is much farther than the ones that you use. All right. So the answer to your question, one, you lose the number of eggs. So the number of eggs declines with time in your ovaries. Number two, there is also a proportional loss of egg quality with time. So the eggs, unfortunately, I would say you lose the better eggs in your younger age. Right. So what you're going to be left with the poorer quality eggs.
And fewer, so, which is not a good combination, is it? God.
It's not. It's correctly. And unfortunately, we don't have a test for egg quality. We can't test egg quality. The only test is when you try to get pregnant and it doesn't work, or you get a fetus with a chromosomal abnormality. That's a reflection of poor egg quality. But there is no lab test or an ultrasound that can tell you, hey, I have good quality eggs or not. That doesn't exist. We can assess quantity. We can definitely assess quantity. We have lab tests for that. We have an ultrasound that we can actually assess the ovaries, count the follicles, but we cannot assess quality.
When I started to learn after being a surrogate, I had talked with a doctor who was talking about as an egg donor, there's reasons why they cap it off and limit the amount of egg donations, because if this person decided later on they did want to have children of their own, so it kind of plays into that part of, if you do too many egg retrievals, you're losing not only the amount, but then when the time comes, the quality if you wait too long too. So it sounds like, is that correct?
Yeah, I guess what is the reason for limiting the number of egg donations that a person does? Totally changing.
We're just so curious. Sorry.
Correct. So about regarding the number of donations, it's related to other considerations. It's related more to what's the likelihood of having then kids that happen to be relatives and they get to get because the more you donate, the more likely that in the future your future children that you don't know about may get together and start a family without knowing that they are actually half brothers. So that's one of the reasons. The other reason is that there may be accumulated damage from egg retrievals. And again, nobody has really done a study on that, but that's kind of, I don't know if I call it common sense or it's just we call it an expert opinion. I mean, we think that that's kind of what it is. But there may be a cumulative damage to the ovaries that may result in adhesions or God knows what, and then maybe that can make that egg donor infertile in the future.
Would that be damage from the egg retrieval process or from the
Possibly.
medications of stimulating the
Possibly,
ovaries?
yeah, the
or
egg
both?
retrieval, and maybe both,
Retrieval.
but the procedure. I mean, you do multiple procedures on a donor. I mean, it can be damaging, even without you knowing.
Yeah.
But to touch your question about, is it gonna really harm the number of eggs that person is gonna have in the future? The answer is no, because, or as far as we know, it's no, because really, remember what I said. You're losing, let's say, hundreds of eggs every month, right? On average, without knowing, without you doing anything. It's just like naturally you lose them. When we actually stimulate the ovaries to retrieve eggs, right? To try to collect eggs through an IVF process, what we actually are doing, we're actually rescuing. Okay, and that's the right term. We're actually rescuing those eggs that you would not you, but the patient would otherwise be losing.
Yeah. Wow.
So we are not, so like I said, you either use them or lose them. You don't retain those eggs. Those eggs are not going to be, if you don't do the egg retrieval, then you're going to use them in the future. I mean, they're going to be lost. So whether we get from a patient 10 eggs or 60 eggs or 100 eggs, I mean, we don't typically get 100 eggs, but let's say we got 30, 40 eggs. Those eggs would not diminish from that patient's ability, that she's not going to get menopausal sooner because from someone we got 10 and from her we got 50, then she's going to get menopausal sooner because we got so many eggs from her. She would have lost those eggs anyway.
Yeah.
So basically you can't, it's not like there is a method you can keep your eggs in your body.
They're going whether we like it or not.
Unfortunately, yes.
Yeah.
Okay, Casey, so we were both partially right.
I'll take that.
I love that. I love that.
I would say that you are both right.
Oh, man. I love that we are learning all the time. I've been doing this. My first journey was, he's going to be 15 this year as a surrogate and went on to do another journey. But there is ever evolving, beautiful opportunity for science growth and really imagine how exciting it's going to be if we can start to get to a place where we get to test an egg and then not have to wait to be fertilized to do that. Like, how beautiful that's going to be when we can get to that place, and what does that look like?
Because something I think that's scary, if you're a young woman and you want to freeze your eggs and you wanted to freeze embryos, like there's no guarantee that you're going to be with that same partner by the time you want to use them. And so if you freeze them with a donor, even by the time you want to use them, you might have a partner who wants to fertilize your eggs. So it's kind of a gamble either way.
Yeah.
Well, you can do both. So again, I know it's not cheap, and I'm not saying that that's like easy for patients to accomplish, but we do offer patients all the options, including freezing only eggs, freezing only embryos, or freezing both. And sometimes it may not be enough. Like, remember what I said, like there is some patients are going to have a high ovarian reserve and we can get a lot of eggs in one IVF cycle. And some are not going to have a high ovarian reserve. And even if they are young, they may have a limited ovarian reserve. And let's say we get only 10 eggs. Then if you get 10 eggs, then what's the chance you're going to have 10 kids or let's say 4 kids out of 10 eggs? It's not very high. And then you have the option to do multiple cycles, to collect as many eggs as you feel comfortable. Like we give you a statistic. We tell you, okay, if you freeze 10 eggs, then that's the chance to have one kid. If you freeze 20 eggs, you have a higher chance to have at least one kid. If you freeze 60 eggs, you're going to have a higher chance. So usually most women are not going to be able to freeze 60 eggs in one cycle. um, it's so some are going to do it more than once because they plan to have a bigger family and they want to make sure that they have enough eggs to get them at least so many kids. When you freeze embryos, like I said, you have more information. You know that you can test those embryos and you can make sure that they are chromosomally normal. And finally, you can freeze both. You can freeze some eggs unfertilized and some fertilize them either with partner sperm or donor sperm. So if you freeze them with a partner sperm and then you are not together with this partner in the future, that can be a problem, right? Because the partner owns those embryos as well, and he can decide to deny you using them, and you may not want to use them either. So then you have eggs that are unfrozen, and that's your guaranteed or that's your backup plan in case you can't use those embryos in the future. So freezing embryos, yeah, it has advantages. Again, you know more information, and you basically you can make informed decision more easily than just freezing eggs. But they don't belong to you only. And if you freeze them with donor sperm, again, you may meet someone in the future that may want to have his own biological children, and that's not going to help you freezing those embryos. I mean, so
then one of you is going to have to choose. Well, we can use get an egg donor, and you can fertilize some embryos, and we can use mine that have this donor. That's so interesting.
If you freeze eggs, then they belong to you.
Yes,
the eggs belong to you, and with all the disadvantages, that's a big advantage. You don't have to, nobody else owns them. You own them, and you can then, decide to fertilize them any way you want.
Yeah. Yeah.
So by the age of 30, I know obviously it'd be ideal if you could freeze your eggs at 19, right? Do an egg retrieval, you're going to get a bunch of really wonderful eggs, but then you have to pay to keep them stored and frozen for so long. So really by the age of 30, 32, if you haven't had children yet and you want to preserve your fertility, would you say that's the point where you need to make that decision?
So I think, again, ideally between the age of 30 to 37, I think that's the target. That's the main target group. If you are already beyond 37, it also doesn't mean you can't do it, but you need to understand that then the eggs that you're going to freeze are going to have a lower chance of being successful. And if you wait until you're 44, I mean, after the age of 44, I think the chance is going to be so small that it's probably not practical. I mean, and again, we always tell patients, we explain, we never, well, I'm not going to tell a patient, hey, it's zero, but practically it will be zero if it may be zero if you decide too late.
Yeah.
So yeah, the younger, like you said, if you the younger you start, if you would do it at the age of 19, I mean, the likelihood that you're going to use these eggs is smaller because you are more likely to meet someone and have children, without having to go through this process. But the older you get, if you correctly said, if you are not ready to start a family, then that's a good time to start thinking about it. And acting on it. I mean, actually thinking about it is not enough.
Yeah, you got to get to it. We get comments on our social media, ignorant comments from people who have ideas about surrogacy or surrogacy requirements or infertility. And so we wanted to give you an opportunity to respond to some of these with your professional expertise.
Okay, honestly, I believe the baby will carry some of the surrogate DNA because of the placenta and umbilical cord. That's more logical. I mean, as far as I know, that's not correct. The baby is the product of the sperm and the egg, and that's it. And the sperm and the egg, as long as they didn't come from the surrogate, which is not, in the old days, we used to do what's called traditional surrogacy, and I don't practice that. I mean, so as long as the egg did not really originate from the surrogate, it will not have any DNA from the surrogate.
So the baby doesn't get DNA from the placenta and umbilical cord?
Not, I mean, no, the answer. So it's not in his, he may, there is free DNA maybe flowing. No, the answer is no.
I have one more for you, so I'll just chat it. It's another short one.
Okay. I just hate, I want to help families, but you have to be a certain size, like the baby's going to be fat because the surrogate is fat. Um, I don't think that that's true. I mean, that's not correct.
Yeah.
The surrogate, may have her own lifestyle and her own metabolism. That doesn't necessarily imply that the baby is going to be as the size of the surrogate.
I think a lot of
And
people that want to be surrogates are discouraged because there is a BMI requirement. And so they think
okay.
that the BMI requirement is there because they're guessing why. So do you want to share why there is a BMI requirement for surrogacy as you understand it? And do you see surrogates in your practice?
Yes, of course. We see surrogates um, and for different reasons. I mean, patients need surrogates, and that's really like an unbelievable process. I mean, I'm always in awe when I participate in this type of reproductive scenario because it's awesome that it exists. But um, the reason for a BMI is not doesn't have to do anything with the size of the baby. Eventually, it's more um, with the likelihood of complications, um, you know, perinatal complications. So when you naturally conceive, either through surrogacy or through any process, you're going to gain weight during pregnancy. Most women are going to gain weight, and the higher the BMI, you're going to gain. You're expected to gain even more weight during pregnancy, and that can be significant. That can be associated with significant risk during pregnancy, which is mainly, it's hypertension, diabetes, and then if you end needing a C-section, the C-section can get complicated, and there is a higher risk of complications during a C-section. It's just harder to want to do a C-section on a patient that has a higher BMI. And number two, the complication rate is going to be, you can get more likely to get infections and wound the Hissens. So though I think that those are the main reasons. It's not. I mean, those are the main reasons for limiting the BMI or having a recommendation about the BMI. It's mainly to protect really the patient and the future baby, because if something happens and you have a difficult C-section, you can't rescue the baby in a timely manner because the patient is very large, then it can cause both the patient and the baby uh, with life consequences.
Yeah.
So this is the reason. I don't think there is any other agenda there. We're not like.
I think people just need to understand that I think people feel judged for being overweight, and so they assume that it's about that because so many other areas in their life they've been judged about their weight, and they don't understand that this is not a judgment. Nobody is concerned about what you look like or anything like that. It's about your health, and it's about protecting the outcome for the baby and for you, for you as a surrogate. It's too risky. So
Yeah.
Correct.
Yeah.
And it's exclusively, it's just to we're worried about the welfare of the woman, of the carrier, of the surrogate, and the baby, and the surrogate is as important as any patient. I mean,
Yeah.
she's carrying the baby. I mean, for Christ's sake, that's so she's very important.
Necessary to
More
protect.
more than the intended parents. I mean, the intended parents are going to get the baby, but
Yeah.
the surrogate is the one that carries the baby, and she needs to
Yes.
be she needs to be cared for, in the most perfect manner
She
possible.
needs to go home to her family
Yeah.
at the end of it.
Exactly.
Usually, I mean, the surrogate is going to have her own kids, and once she's done with this adventure, she has to care for her own children, and her kids typically need her.
Yeah.
So we want the surrogate to be healthy and well, and we always have the full respect, and we care for the surrogates really more than and any other patient.
In your experience, is there any misconceptions or myths that you have heard with regards to fertility preservation and really kind of that process? Anything that you could debunk?
Yes. I mean, there are some. Most interestingly, I think that the major misconception is that, well, I shouldn't say that, but one of the things that um, in social media and media in general are emphasized is that, oh, women are choosing to have a career, so that's why they delay childbearing, and actually, that's probably not the truth. The truth is that, there are many women that would like to have kids today, but they are not in the right relationship.
Mm-hmm.
And really, this is the major chunk of population. It's not that women that oh, I'm doing medical school now, I'm doing law school, I'm doing whatever, and I don't have time for that. It's actually not. It's actually the women that are just not in the right uh, situation in their life to start a family. They don't have the right partner, they don't have a partner, or this is really the major. So I think, again, when people talk about this social egg freezing, they mainly refer to professionals. Oh, all these professionals, they delay child, but that's not the truth. That's partially, I mean, that's true. That's correct, but that's not the major chunk of the population. The other thing that is maybe a myth or a misunderstanding about egg freezing is, what I alluded at the beginning. It's a backup system. It's a backup process. It should not be. You should not consider that a guarantee. If you consider that a guarantee, that's wrong. Then it's a big misunderstanding, because unfortunately we are not yet at that stage that we can guarantee a woman that, yeah, you're going to have a baby because you froze your eggs. Uh, you freeze a chance, and that's what it is, a chance. So if you are, in your early 30s to have a kid, you freeze a chance of 70%. If you do it when you are 40, you freeze the chance of 30% for the same number of eggs. So again, it's a chance. So remember, 70% is just 70%. So there is a 30%, even if you're young, that it's not gonna work.
Yeah.
Um, I think I mentioned the other main thing that people are concerned about, and they think that if they undergo this process, they're gonna get menopausal sooner. That's a totally misunderstanding. Like I said, you either use them or lose them. You can't. It's basically what we do. We rescue those eggs by doing this process. We rescue them, and you're not going to get menopausal earlier. And maybe lastly, one of more topic that I wanted to touch is, I think, again, many, and this is the lack of awareness regarding all this fertility process. Many women first think that, unfortunately, their fertility is going to last forever because, they eat healthy, they are fit, uh, they take their supplements, they exercise, whatever. And I think all that is great. And I'm a big supporter of and advocate for a healthy lifestyle, for, take your vitamins, do everything that is right, don't smoke. Unfortunately, that's not really always, or more, it's not protecting your ovaries. It's not protecting your fertility. I mean, if you do the wrong things, it will damage your fertility. Definitely, it will enhance your losing, the damage to your eggs, and losing eggs sooner, and basically getting or causing, reducing your egg quality. So you can do active things to reduce your egg quality. Unfortunately, there is not much you can do to improve your egg quality. I mean, it's not totally correct. I mean, you should again maintain a healthy lifestyle, but the main factor for egg quantity and quality is age.
Yeah.
And there is nothing. People think that physicians are magicians. We're not. We cannot reverse the damage of time. We just cannot do it. So even we try the best, we try our hardest, we cannot do that. And I think that's a huge misconception. People think that IVF, oh, worst case, I'm going to do IVF. I'm fine. Worst case, I'll do IVF and I'll get pregnant. That's really wrong,
Yeah.
because IVF is far from being perfect, and in older age groups, the success rates are still quite low. So it's good to keep that in mind.
I'm hopeful that it'll improve more in time, but I want to go back to one thing that you said about that I didn't realize, because I do always refer to like women who are career professionals, they're focusing on something else and so they're delaying their fertility. But what you've just confirmed for us is scientifically it's really hard to find a good man, right?
And if you don't lose them, if you don't use them, you lose them. And I'm going to take that away too.
Ladies, I have 4 girls. I know exactly what you're talking about.
There are not a lot of good men, a lot of good partners out there. That's so sad. And who knows? Maybe us with our eggs aren't the best either, but it's hard to find the right person to build a family with.
Yeah. I can't agree with you enough.
Well, we're all very lucky that we have found our partners and built our families. But I'm so grateful for you for spending this time with us, because I just want more women to know and think about their fertility, because a lot of us do think, oh, the worst case scenario, I'll do IVF. Worst case scenario, I'll do that if I need to. And thinking about these things when we're a little bit younger, I think is really, really important. And so I continue to tell all of my friends when they get into their late 20s, early 30s, like, if you haven't had kids yet, let's think about this. Let's talk about it and, pull the trigger on saving those eggs if it's something that you really think you want in the future.
Those conversations are necessary. Thank you. This has been so, every time I'm like, I want to learn. So thank you for allowing us to have an opportunity to take away so many great realizations for this process. So good.
Likewise. I'm very grateful to you, ladies, and it was a pleasure speaking to you.
So much fun. Thank you, Doctor.